So that's why I do what I do, trying to provide access to good quality primary care to as many people as possible. We currently, in where I work, we currently integrate telemedicine into community pharmacies. As you are all aware, most people go to either community pharmacies or patent medicine vendors before they even think about going to a doctor. And this has nothing to do with level of education. Plus, the educated and the poorly educated, they end up going to the pharmacy first. So we decided that since that's the first port of call for most patients, why not make the care standardized? With that overview, I'll go straight into it. Integrating technology innovations into Africa's primary care. This is my outline. I'll just give a brief overview of the components of the healthcare system, the current challenges of healthcare system in Africa, and then potential technology solution and impact, and then we'll give a conclusion. As Olaoluwa said, I'll try and make this as brief as possible so that we can have enough time for question and answer. I believe he also has some predetermined questions for me as well. I'll be happy to use my experience to explain this to you to the best of my knowledge. So this is according to the World Health Organization. This is what the components and the objectives of the healthcare system should be. There should be leadership and governance. There should be good quality healthcare financing using whatever mix of private, public, general health insurance, fee for services, and all of that. Then the healthcare workforce, and of course, this consists of healthcare professionals, including doctors, pharmacists, physiotherapists, nurses, community health workers, and everybody. Of course, there should be medical products. This includes the medicines, and then, of course, technologies, which includes the diagnostics that we use for diagnosing many diseases or monitoring diseases. Then information and research. We need this for good data. We need good data for planning. Of course, we also need real-world evidence, which we can use for drug registration and monitoring and all of that. And of course, the service delivery itself. These 6 system building blocks, we need it to translate into access to care and quality care, and then the goals of the healthcare system will then be achieved. And those goals are simple. Well, they are simplified. It doesn't mean they are simple. Improved healthcare at all levels, and there should be equity in this healthcare. Responsiveness has to do with timeliness of getting access to the care, and then financial risk protection. Essentially, you don't want people to go bankrupt as a result of their health. You also want them to have financial risk protection as much as possible. You don't have catastrophic healthcare expenditure. And then, of course, you want to improve efficiency. So you want to use the least resources to get the best outcomes, essentially. Unfortunately, all of us in Africa have a problem with every single building block of the healthcare system, from the leadership to healthcare financing to the workforce, medicinal technology, information and research, and then the service delivery itself. And all of these at different points can be improved by technology. I will not go deep into it, but imagine leadership having access to good quality data they can plan. So, so for instance, if you are in Lagos University Teaching Hospital, and you know that on Mondays you have 500 patients walking into the general outpatient departments and all the other clinics, then you can adequately resource the place for how many health records officers, how many doctors, how many nurses. You can use that for planning. Then also you can review the data and see the health outcomes of all the people that that came to the hospital and use that to continuous improvement. So that's where leadership and governance comes in, and how technology can be used for all of this with good data. Unfortunately, if I asked any of our medical directors in major hospitals, what is the number of malaria cases that we received in the last 2 months, he would have to call somebody, the HOD of the department. The HOD will call the health records person. The health record person will call the subordinate, and they go to a file room and start sifting through and start recording. Or they check the book where they've written it. With technology, this can be made easy. With a few punches here and there, sorting, and then you can get the data and the information he needs. And then based on that, you can determine how much anti-malaria or artemisinin combination therapy that he needs to stock. He can determine how many adults, how many children. He can determine so many things by just having good quality data. For healthcare financing, of course, the health insurance sector is a bit of a problem in Africa as well. In many of the African countries, especially in sub-Saharan Africa, we have a situation where it's only people in the formal sector that get access to some form of health insurance, either through the government insurance or private insurance. And unfortunately, more than 80% of the population are in the informal sector. And as a result of this, people tend to spend a lot of money on their healthcare, and they have catastrophic healthcare spending. You can use technology, of course, to improve access to this financing. Number one, you can use technology to improve collection. Imagine using Money Point or OPay, for instance, to collect a token of 500 naira for every single household in Nigeria or every single person in Nigeria. Imagine 500 naira times, let's just say 100 million people. We know we have 200 million people. 100 million people times 500 million. That's more than 10 billion. If you pay 500 naira every month, you can get access to 10 billion. But you can only use technology to access that kind of money because you don't have enough people to go from house to house to collect the money and then use it appropriately. There are many other ways that technology can be used for health financing. For healthcare workforce, we have a big challenge with that as well. We'll talk a bit more about that in a subsequent slide. Healthcare products, we hardly manufacture any medicines in Nigeria. I've been privileged to work in pharmaceutical space where even the APIs, that's the active product or active ingredients for Panadol, is not made in Nigeria. We import it and then we compound and then make it into sachet form. So not to talk of more complex medicines and immune therapy that people are using right now. You have robots that are delivering targeted therapy to brain tumors and things like that. All using technology. We are way, way, way behind in terms of that. And even the research process is also lagging. Information and research, I already talked about that a bit. And then service delivery, you can assess care, you can do surveys and things like that, and also provide trainings and capacity building for healthcare workers using technology. And all of this will contribute to improving healthcare systems. As Olaoluwa said, please note your questions. I know I'm moving a bit fast. I'm aware that we have limited time, and in fact, you can do a whole module on technology and healthcare. In fact, there are now courses on this online and in face-to-face. So I'll move on to the next slide. So the challenges, I already mentioned them. Some of them, we have the highest disease burden. Africa, for instance, has almost 80% of the disease burden, but only about 20 to 30% of the workforce. We also have challenges with access to care, many different types of problems related to access. There's the geographical access, meaning that people are far away from where healthcare is delivered. Unfortunately, healthcare is skewed such that the urban areas have more access to care compared to rural areas, but rural areas have more disease burden, even though there's serious migration and also stretching the existing healthcare system. So there's a geographical access problem, there's a financial access problem, and there's also access to specialist care. For instance, if you go to Zamfara now, you may not find a neurosurgeon. And if you had a head injury, if you had a stroke, you may not find a neurosurgeon for miles and miles. If you go to a place like Maiduguri, well, there's a teaching hospital in Maiduguri, so there might be one. But you go to certain places, you won't have access to certain specialists. You may not have access to dialysis care. So access is a big, big problem. But then we're talking at primary care level. Simple access to someone that can diagnose a pneumonia is also a challenge. The healthcare workforce is limited and skewed poorly towards the urban center. And even within the urban center, they are still not enough. The quality of care is also compromised. And then, of course, we're not managing our data right in terms of data to make policies and also electronic health record. If I go to Loot now, I have accessed care maybe over a decade ago or 2 decades ago. If I get there, they will definitely not find my file because there's no electronic health record in most of the departments in Loot. So what that means is my data is lost. And if I came in unconscious, God forbid, and I have allergies to certain medication, nobody will be able to tell. But imagine if you prescribed a drug with electronic health record, there's already a red flag system that will flag it and say this person is allergic to this drug before it even gets to the pharmacy in the first place because it's already on my record. But we have a problem with data management in our environment, and technology can help us with that. I mentioned something about this earlier on. This is key because this is the basic level of technology that we can use to solve problems. Just access to primary care providers, either a nurse practitioner, a doctor, a medical officer, or a community health worker, just having basic access to that is a big problem. We have a density of 2.7 doctors to 10,000 people. I can assure you that that number has worsened because this is 2018 data with the Jackpot syndrome and everybody emigrating. And I know some medical students are already taking their licensing exams even before they graduate and ready to take off right out of school. That will further put pressure on us in our system, and we will not have access to care. Like I said, this is the basic level of primary care. Having access to a doctor that can just say, okay, this person has a pneumonia, and let's give him appropriate antibiotic. A lot of people don't have access to it. Most of us are in urban center. If we are using internet in the first place, we are most likely not amongst those people that have serious challenges. However, if I needed a specialist, for instance, I can easily make one or two phone calls, but most people cannot do that and get a specialist. And with telemedicine and remote care, you can actually improve access. About that in the subsequent slides. So technology can improve patient access, it can improve health outcomes, and it can also improve patient experience and overall reduce cost. A lot of people underestimate this value of technology where it reduces the overall cost of care. But I can describe a simple scenario for you. Imagine a woman that sells maybe fish in the market. That's all she does for a living, so she doesn't get a salary. If she's sick, she goes to the hospital. So she spends transport fare to go to the hospital. And then when she gets to the hospital, she waits about 2 to 3 hours. She gets some tests done and then she gets a drug. The direct cost of care would include um, the money she spent on transportation, the money she spent on consultation fees, the money she spent on the medication. But there are some indirect costs. First of all, she cannot sell fish that day. And if she doesn't sell fish that day, she doesn't earn a revenue. So that indirect cost is too costly for a lot of people. And a lot of people tend to defer healthcare as a result of that because you have to, it's like between a devil and a deep blue sea. If they don't sell that day, they don't eat. So they need to sell for them to eat. And majority of the population are in this category. Imagine a conductor. If he doesn't earn a daily wage that day, his family does not eat. So by providing access to telemedicine, he sits under a bridge and he can speak to a nurse practitioner, a doctor, a primary care provider, and then right not far from him, he goes to a better medicine vendor, a community health pharmacy, or a community pharmacy, and he picks up his medication. He's not going to lose his daily wage. He's not going to use transportation costs. He may pay a minor consultation fee because the cost of consultation will most likely be lower than having to go to a brick and mortar location. For instance, in Nigeria, I have 60 telemedicine sites in Nigeria that are within my control, and I use just 8 medical doctors for that. So what that means is, yes, even if I pay the doctor the regular wages, it won't cost me as much overall in terms of operating expenses if I had a hospital. If I had a hospital, I'll have to have hospitals in at least 30 locations to be able to provide this same level of care. But with telemedicine, my doctors can work from home and consult in 60 different locations across different states in Nigeria, right out of Lagos. So it's more cost effective for me, it's more cost effective for the healthcare provider, and insurance companies too is more cost effective for them, and of course the entire healthcare system. So we can reduce costs with technology. In the next slide, I'll just talk about the technology solutions briefly, so that over the next 5 or so minutes, I'll just talk about the technology solution and potential impact of them. And then we can then go into the questions from the moderator. Number one is telemedicine, which I've already touched on. It's such a simple solution. And we already do it anyway. Consulting via WhatsApp, consulting via phone calls is telemedicine. Telemedicine essentially is just connection between the healthcare provider and the patient without having physical contact. So any way you do that without physical contact is regarded as telemedicine. We do it already, but we can improve it. At M Pharma, for instance, we've added another layer of technology to it. We have a device. It's called the TitleCare device, a TitleCare Pro device. With that TitleCare device, You can have remote examination. So it has, I wish I put a picture of it. I can listen to the chest from a remote distance as long as there's internet access. I can listen to chest. Even if there's no internet access, it can be recorded and sent to me from a remote location. I can look into the throat, look into the ears, listen to bowel sounds, listen to breath sounds with this device remotely. With technology, we can incorporate that so it will have some sort of hybrid. Um, in the US, in Israel, and many other countries, patients have these devices in their homes. They connect to their doctor, and then the when you have the app on your laptop or your tablet, it shows you where to place the device, so you can do it yourself, or you can have a nurse do it for you remotely, and the doctor is listening at another location. So with telemedicine, we can improve access to good quality primary care and even specialist care. People forget that part. They assume it's only primary care that can be done via telemedicine. But imagine that I needed to see a cardiologist and there's no cardiologist in my location. I can I can connect to one via telemedicine, have a discussion. He can order his test. I can forward the results to him. They can have real-time monitoring. I can consult with an endocrinologist. Uh, Telemedicine cannot solve all the problems, but it can definitely bridge the gap. That patient that is in Adamawa State that does not have access to a, a, um, say a neurologist, for instance, a neurologist, if it's not an acute emergency, you can connect remotely and then have that consultation, and then you can send the prescription also digitally, and then they get it from anywhere close by. And even if they cannot get it, this can also be transported using technology. Some people use drones in to transport blood products. If you've heard of Life, is it Life Bank? Yeah, I think it's Life Bank. They use drones to transport blood and blood products, vaccines to difficult to reach areas. And all of this is all technology with the backbone of telemedicine on it. So essentially, telemedicine solutions can connect patients in remote areas, in difficult to reach areas, enable consultation, and also enable monitoring. M Health. People forget M Health in terms of technology. Apple and Co. are beginning to revolutionize mobile health. Um, you have your iWatch where you can have your ECG done, you can have your SpO2, your oxygen saturation done, you can check your heart rate. In fact, some can even check your blood pressure, and this can be transmitted live to another location. And in the latest iWatch, you can have fault detection, can have crash detection. So if you are in an accident, based on the movement of the hands and movement of the body, it can send an immediate signal. This is all technology-enabled solutions to improve health access. Imagine your mother in the village now, you bought the iWatch for her. If she fell in the bathroom, God forbid, you have an alert, and then you know there's something wrong, and then that can be the difference between life and death, because you can easily send someone over to go and check up on her and all of that. So M Health, you can also provide education to patients. You can provide education to healthcare providers. You can also have AI chat box. For instance, you log on to, it happens many places. It's just that healthcare is a bit slower, but it's already happening in some other locations. You log in online to say CVS Health, and then you get a pop-up. Do you want to speak to a doctor? You chat, you put in your complaints, and algorithm determines if it's an emergency and triages you to either go to the hospital or you can speak to a doctor remotely. Simple chat box can ask simple questions. Okay, I have X, Y, and Z. What do I need to do? And it can give you the solution. All of this can be enabled by technology and artificial intelligence. The electronic health records, I spoke about this earlier. Like I said, imagine I was brought in unconscious and my records cannot be found. My records cannot be found, and somebody gives me a drug I'm allergic to. That could be fatal. But if you have digital electronic health records, this can enable us to store all your data in the cloud solutions. And if you store your data in the cloud solution, you can access it anywhere as long as there's some interoperability between platforms or hospitals. You can access your data. And in some locations now, you have your own health records and you carry it up and down with you wherever you want to go. So electronic health record is very key. It also helps with basic research. Like I gave example, I gave how many malaria cases did we have last month? Based on that, we can plan for this month. And then we can also detect, okay, so for some reason, we have 7 cases of dysentery, and then you can do a survey, where are all these people from, and you can map if there's an impending epidemic of dysentery in a location using technology. Because on that electronic health record, if you say there were 5 cases of dysentery, okay, 5 cases, you can easily check the address of all the patients, and then you can see that there's a cluster around one location. Then you know that there's something happening there. Using technology, you can prevent further spread and outbreak. You can send your epidemic surveillance or epidemic intelligence personnel to go there and find out what's the issue. Just having electronic health record. Um, Private hospitals already have this. If you go to Lagoon, for instance, if you saw a doctor, a cardiologist in Apapa, and then when you are done, maybe a month later, you move location, you now want to quickly see the person in VI, they can access your record without missing anything. So you know the doctor knows what has been prescribed for you. They know what kinds of things you may or may not be allergic to. They know your last blood pressure reading, your last ECG reading, because everything is right there in front of you. So electronic health records simplifies things and improves efficiency in the healthcare system. Electronic health record can also be used for real world evidence, for research. So, for instance, when you are doing pharmaceutical research for new drug introduction into the market, what we do is we have what we call inclusion criteria. We have very specific group of people: patients who do not have comorbidities with this, that, and that, patients who are not smoking, patients who are above a certain age, patients who are, so they have a clean criteria. And then they provide you with the data and tell you the efficacy of the drug is superior to existing things. But in real world, that same patient who had this hypertension that was in the clinical trial may also have coexisting diabetes, he may have arthritis, and may be using other medication with it. You can then compare real world evidence of this drug. Is it as good as they said when it was done in clinical trial, which was a very neat population, a very pre-specified population? You have inclusion criteria, you have exclusion criteria. So you can use electronic health records for real world evidence research. And this is is getting to become gold standard. I know we do randomized clinical trials currently, but real world evidence is beginning to take more weight in many countries as to how these drugs are, what they consider superior, and what they consider reimbursable treatment. Because in the clinical trial, yes, it may be good, but when you are using it in the real world state, it's not as perfect as it is. Health information system is another one. This is used for general planning of healthcare. Having health information system, it can help us with pandemic preparedness, it can help us in data monitoring, it can help us with better resource allocation. If you know that in Ogun State we have more cases of diabetes, then you know that you can deploy more endocrinologists there. If you are working in a federal medical center and things like that, you can use that. If you note that in Bayelsa State you have more chronic obstructive pulmonary disease, you can deploy more of your pulmonologists there rather than concentrating everybody in Lagos, just because Lagos is an urban center. But you can deploy more of your pulmonologists to federal medical centers in Bayelsa, and then you can then decide, okay, what is it that's causing this chronic obstructive pulmonary disease? Essentially, when you have adequate healthcare information system, you are better able to allocate your resources and prepare for pandemic. You can even do predictive analytics using the data you have compiled over a period of time. You can teach the artificial intelligence, machine learning, to be able to make predictions, reasonable predictions based on data that it has put in place. For diagnostics too, you can also use technology. You have portable rapid diagnostic testing using technology. Back in the days, for you to do a full blood count, you had to travel to a major lab. Now, with a finger stick, less than 10 microliters of blood, you can run your full blood count using advanced technology. And even now, if you don't have a radiologist, you can have your MRI done, and AI will interpret the results almost as accurate. I'm sure you've heard of Google Palm something, is it Palm 3, that is now scoring better in USMLE than even humans. So technology is going to take over eventually in some areas. So technology, people are afraid that technology will replace humans. No, technology will not replace humans. Technology will replace the humans who refuse to adapt to the technology. Imagine the people that refuse to adapt to touch screens like Nokia. They got swept over. You can use technology also for training and capacity building. This will help improve quality of care. For instance, it was introduced. I have a team of over 100 and something people across different countries. With technology, I can carry out trainings and certification exams for my staff, for my team members, and this will help me improve the quality of care. There are many, many more technological solutions and their applications in healthcare to improve health outcomes. However, this few that I'm uh, stating here is just to open your mind to the possibilities that exist out there, and there's so much more. There's so much more. AI is already helping with diagnostics. You input your systems, it gives you the differential diagnostics and tells you what to do to rule out each one of them. Before you know what's happening, a lot of algorithms are put in place, and you can use AI to do effective triaging. You can use it for effective prescription, effective monitoring and follow-up of patients. It can even alert doctors when there's an emergency. Many things, many things. The potential is endless. In fact, I don't think we can comprehend it yet. But over the next 5 years, the evolving role of technology in healthcare is going to become more apparent, and those that refuse to adapt to it will be left behind. So, in conclusion, integrating technology and innovation to Africa's healthcare system holds an immense potential for overcoming existing challenges. Of course, by focusing on the building blocks which I started with, the building block of the healthcare system, and strategically deploying technology in all of this, it can pave the way for more efficient and accessible, high quality healthcare service in Africa. Thank you very much.
Thank you so much, sir. And that was brief, succinct, and covered most of the areas. And I particularly keyed into some of the points you made about data and problems with catastrophic healthcare spending. I recall an article I was working on health budgets per state in Nigeria, and I remember that I had to go to. In fact, most states in Nigeria don't even publicly publish
Yeah.
what they are spending on health. So I had to start going through media releases state by state, and even at that, I think I was not still able to get up to 6 states. That's 1/6 of the states in Nigeria. So thank you so much, sir. And I think I gleaned so much from that. So we are going to first go into the questions that I had prepared. Then after that, we can then take questions from the audience. So that will be by typing into the chat box. Then we'll then take it one by one.
Good.
Okay. So my first question is based on something that you acknowledged, talking about the access to care, especially for people who are not um, in higher socioeconomic status, people that cannot even afford things like smartphones that give them an advantage, give them a leg up as regards telemedicine. Now, the NPHCDA, that's Nigerian Primary Healthcare Development Agency, says that 6 out of 10 Nigerians already lack access. That's about 6/10, or breaking it down to small numbers, 3 out of 5 Nigerians. And now, how does technological integration help us attack that number? That's the 3 out of every 5 individuals, especially targeting those people that cannot afford access to things like telemedicine, that cannot afford those indirect costs of care that we already assume they need, things like smartphones. How does technological innovation help us tackle that?
Yeah, thank you for that. So if you notice during the cash crunch, not this 2023 cash crunch, the 2022 one, where there was almost confiscation of all the naira in circulation, these were the people that were significantly affected, and they needed help from other people. So one of the first things that we can do is, of course, have things like booths. So it's not a health center. It's like a kiosk. Okay. In this kiosk, there is simple. There can be a simple tablet that can help them. There are many low budget tablets that you can use in their different languages. If you go to ATMs now, uh, they can it will ask you which language you want to use, so you can translate a lot of things in simple language for people, and they can just go to this information booth and get relevant information they can use. Some people actually use USSD. So for instance, um, if you want to speak to a doctor, press 1. If you want to talk about your medication, press 2. You know, those kind of things. Very simple things like that, and it can be said in their own local language. So while it's better to have a smartphone and all of that, they are not essential for basic primary care. They're not essential for basic primary care. For instance, you can even create algorithms for diarrhea. For instance, you 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 call that of course there will have to be publicity and education and information awareness. If you have any healthcare problem, press 11111 5 times on your phone. Once you press 111, everybody knows that this is a healthcare condition. Then the prompt comes up. If you have, so it will be for some basic conditions. It will have some basic conditions like you have. So where I work, we have a list of 14 diseases that we say we want to take care of via telemedicine, because telemedicine, like I said, cannot solve all the problems. So you have a list. You know that priority diseases in children will be malaria, will be diarrhea, will be pneumonia. Let me see what else. Maybe a rash. So if you have a rash, press 4. If you have a cough, press 1. If you have a diarrhea, press 2. Something like that. Make it as simple as possible, and then they'll get a guide on what to do. This prompt will also tell them what, and it doesn't even have to be a human being responding on the other end. AI will do this for you. Tell them clearly, if after 2 days the patient does not feel better, go to so and so place. Or if the temperature, if you touch the body, it's in hot, well, please carry and go this place, or use mop, use a towel, use water, wipe the body. This, they can get basic help, basic information. Because what will kill a child with diarrhea is dehydration. If you say, go carry sugar, take your small spoon wey dey take feed your baby, put 5 spoons and 1 spoon of salt inside water, give am drink. If the diarrhea continue after 2 days, for every time e shit, give am 10 spoons, 10 adult spoons. For every shit, give am 10. So basic information, and AI can do all of this. My pastor recently did a conference, and the conference was translated into French with him speaking, with his mouth moving. You will see him like this, you see his mouth moving, and he's speaking French. Yet he knows no word. Apart from bonjour, he doesn't know anything else. And you look at it and you think he was speaking French all with his own voice, with his own tone, with his own accent. You can do this in Yoruba, you can do this in Igbo, you can do it in broken English, you can do it anywhere. So we just need to be more interested in these marginalized populations. We have to be more interested in them. If we really want to solve their problems, there are solutions, and technology can make it efficient for us. I hope that answers the question to some extent.
Yes, sir, you have. Thank you so much. I never even thought about it like that. Considering the fact that we are supposed to have like a PhD in every local government or every ward, I think we even have like somewhere that you can start
Mhm.
integration of things like the boots that you mentioned.
Yeah.
And I think that leads me to my second question. Um, so you're a consultant in Nigeria. I'm
Yeah.
presuming that the vast majority of people on this call are either medical students or that's studying medicine and surgery, or will be in the healthcare space. There's the other departments like physiotherapy and nursing. And we know the attitude that most of our teachers, most of the leaders in this field have towards technology, probably more of disdain or making people lazy and whatnot. And then that goes further to affect their approach of its usage in healthcare delivery. So, in your opinion, how do you think we can approach training healthcare professionals and building the ability to effectively use technology, especially in primary care settings? I mean, the matrons in villages, or, and for example, I'm currently working in Ogbomoso. I think it's safe to assume that the matron in a PHC in this place is less likely to adapt to technology's usage. So, how do you think we can go about this? How do you think it can be tackled, sir?
Okay. Yeah, thank you for that. That's a very brilliant question because we keep talking technology. I remember when I first started working in the corporate world, I didn't know how to use Excel because as a clinician, I did not do any of this. Even making PowerPoint presentation. If I told you I made this PowerPoint presentation just 1 hour ago, it might interest you. So I know where to go, I know where to get it, and all of that now. But back then I didn't. I had to learn. Now nobody wants to do self-learning. A lot of people don't want to learn on their own. But for the good of the healthcare system, there needs to be an overall systemic way of approaching it. First of all, for your personal development, you need to learn it. But for the good of the healthcare system, somebody needs to take charge from the healthcare ministry. For instance, in the UK, there's a digital academy for healthcare professionals because, specifically because of what you just asked, the older generation, who unfortunately in healthcare, unlike other sectors, where the younger generation are the ones changing everything and are the ones that are the most qualified. If you go to the tech industry, the younger people are the most qualified. What my daughter does on her phone using CapCut and using all these apps to do things, I'm like, oh my goodness, I don't know how to do them. But in healthcare, unfortunately, our most experienced hands are older generation. We cannot discard them because of technology. So we need to have an approach, a concise approach to ensuring this. So this Digital Health Academy for healthcare professionals in the UK was set up specifically because of this. A lot of things are changing now. I remember there was a time if you wanted to remove a gallstone, you had to make a long incision in the subcostal region. Now you use scopes. You make 3 punches in 3 hours. The patient is out of the hospital. Nobody wanted to do it. Eventually, everybody learned. So we need to have a comprehensive approach to digital transformation. We need to have a comprehensive approach to digital transformation of the healthcare system, especially the public healthcare system. Private sector people always drive the innovation. They will train their people and do everything. They have the smaller people, they have the budget, they have the interest because they know that their patients need it. When I was consulting in Premier Hospital, as I'm talking like this, my patient is checking on the tablet, so I better know what I'm talking about. In the public sector, you can tell them anything and then they'll take it hook, line, and sinker. You need a comprehensive digital health training approach. Start from the basics. Basics. You don't need to know everything. You don't need to be coding. You don't need to learn how to code, but you need to know the basics of how to enter electronic health records, how to access the data, how to prescribe electronically. Then you now move to more advanced stuff like doing laparoscopic surgery. I know laparoscopic surgery has now gone another level. Somebody can be in India controlling the robots in Pakistan and they are operating. So it's you take it step by step, but there has to be a plan. There has to be a deliberate interest because we know technology will take over. All our parents, phones came out, you come, jojo, wá me tẹ kinní kan, they call you to come and be helping them dial numbers. After a while, they were forced to learn. We are not saying they will learn how to play Call of Duty on their phone, but at least they can do the basics. And that's where we need to start from. And then we move it up from there. There's something one of my former managers told me. He says, clarity comes with motion. If you do not start, you cannot continue to improve. You need to start from somewhere and then gradually improve on whatever it is, whatever level you are in. And that's the best we can do for now, at least from my own opinion.
Thank you so much, sir. I personally agree with what you've mentioned about clarity and motion. So we'll tilt more towards your personal experiences, your journey with your health tech startup,
Yeah.
and drawing from the journey so far. What will you say the major challenges that personally and professionally you've observed with your health and technology integration, and what were the lessons that you learned from it?
Okay. Okay. So the challenges are on different levels, from the patient's perspective, from the healthcare provider perspective, and then from the health system's perspective. I'll start from the patient. When we told patients that you can talk to a doctor within this community pharmacy, they assume that when they get there, they will see a physical doctor. And when they get there, they see a tablet and they're upset. So we need to, so the first thing was reorientation. This person is there live with you. Most of our diagnosis comes from history, maybe up to 60%. You complement it or reinforce it with examination, get it to 80%, and then involve diagnostics to get it to almost 90%. We can't get diagnosis right 100% of the time, but we started speaking to them. We started convincing them that look, it's just as good. Then what we now did was we had a hybrid format. So I told you about title care device. That title care device enables us to be able to do remote examination. So we had a nurse within those pharmacies, or we call them health assistant. So it gave them a feel of what they would do in a hospital. When you go to the hospital, you do your vitals somewhere. So this person will do all of this for them and transmit the results to the doctor, and the doctor sees it. So we learned quickly that people don't want to talk to a computer. So we had that hybrid model of including a nurse, and then we now took it further by having the title care device for remote examination. So from a patient perspective, that improved it. And every week we have over 1,000 patients that consult with us using telemedicine across different parts of the country and across different countries. The next thing, from the healthcare providers' perspective, a lot of people were against it. First of all, as doctors, they don't want to just sit down somewhere and be talking to a computer. Secondly, people did not feel, why would you take healthcare to the patient? The patient should come to us, because we are used to sitting down in our office and the patients come. Now we are taking the healthcare to them by using remote access. Again, we have to do reorientation on this. And look, these patients will not come until it's really bad. If you institute health promotion activities, preventive care, and early detection care, then you can improve the health outcomes. As after all, you said you're a healthcare provider, and we are here for the patient, and we need to improve the patient experience. So we're based on that. We try to reorientate the healthcare provider. Also, from a patient and doctor perspective, we added besides the title care device, we also had rapid diagnostic testing. Of course, we cannot do all the tests in a pharmacy, for instance. You still have to go to the lab, but at least the basic rapid diagnostic test, we made it available so that the doctor feels comfortable that, okay, I can get a few things for it. And from a health systems perspective, oh, that was the biggest challenge. In many states in the country, there is no regulation on telemedicine. No regulation. So we told them we needed a license to do telemedicine, and they are saying, what do you mean? Some will tell us we have to have a brick and mortar hospital, we need to have number of beds, we're like, we are offering telemedicine. All we need is computers, we need a comfortable room, a quiet place, noise cancellation headset. So we were the ones telling a lot of people what is required to offer this service. So more and more states are beginning to adopt it. I know in Bayelsa, in Imo, of course, Lagos State always sets the standard in Nigeria. Lagos State actually gave us telemedicine license. But note, this is Africa. In Ghana, they had the same issue. In Kenya, they had the same issue. In Uganda, they had the same issue. In Rwanda, they had the same issue. So it's not a Nigerian thing. All of them were not prepared. Even after COVID told us that telemedicine will become a big deal, they still were not prepared. There was no regulatory process. So apart from that regulatory process, there was now the issue of and doctors say they must come to the hospital, as in from a association perspective. Said no, we are here for the patient. If the patient goes to the pharmacy, they will go and meet them there, because whether we like it or not, they will go there. They will go there. Why not improve the quality of care they're receiving from there? That's the question we asked. And a lot of people, a way to get professionals is to name and shame. That's one way. If you tell them that, look, you claim you are interested in the patient's health outcomes, they go to the pharmacy. You know that people just prescribe all sorts. There's antimicrobial resistance. There's improper use of anti-malarials. Why not improve the quality of care by providing some sort of services? And then they will now say the PCN had issues that they don't want doctors in the pharmacy. You say the doctor is not there. There is no doctor in the pharmacy. It's a telemedicine device. You can do it. And you know what? What we are doing is no longer new. Go to CVS, go and check, Google it. One Health, Minute Clinic, CVS Health. It's actually an entire healthcare chain from CVS alone. They have chief medical officers, they have medical directors, they have doctors and everything. CVS Health. Go to Walgreens, they have their own. The NHS has also started it, providing care through the community pharmacy. Whether we like it or not, things have to change because convenience, cost effectiveness, and basic care is, we're not asking for highfalutin things. We're not telling them to go and do x-rays or ultrasound scan, even though there's AI powered ultrasound scan now. You put it there, the thing will interpret it for you. It will interpret it for you. You don't need any additional 5 years of residency training to be able to do a scan. It does it in for majority. Of course, there will still be some errors here and there. So we face challenges with the health system. We convinced quite a number of people. So we have licenses across Nigeria, Ghana, Kenya, Uganda, Zambia, 5 countries right now. We had challenges with PCN and all of that. They have now come on board. Lagos State is now, in fact, calling us to partner with us. So we are navigating it. We are in a new space, sort of. It's not new, but we are sort of navigating it and we are learning as we go. My boss, he said something. He said it's easier to say we are sorry than to ask for permission. That we should just go ahead. So we started and then we navigated through the challenges. So from a patient, healthcare provider, and then the health system perspective, those are the different challenges we faced and the solutions we provided. Thank you.
Thank you so much for that, sir. Um, Drawing from that same experience, what next steps do you think, or what next step in technological innovation will be the next big leap as regards primary healthcare improvements for us? Because of time, we can just maybe bullet points and for people to further do their research on their own.
Okay. So decision making in terms of making diagnosis. So community health workers will have a tablet, punch in one or two things, he brings out a diagnosis. That's one thing that will happen. We don't have a choice because we don't have enough primary care providers and we're not everywhere. So that's the AI is going to take over quite a lot of primary care diagnostics, and the triaging and diagnosis process for primary care. Next things that are going to happen is radiology. A lot of the radiology AI is going to interpret it for us, and telemedicine will become mainstream. Home care will become a normal thing. People will have, while I'm in the office, I have a 30 minutes break. I quickly speak to my healthcare provider via my phone. So telemedicine is going to become a big deal, and it needs to be integrated and effectively accepted. Is coming, and there's nothing we can do about it. Your ECGs will also be interpreted by AI very soon. Your remote monitoring, like I said, fall detection on your Apple Watch, ECGs on your Apple Watch, live direct monitoring is happening on a daily basis. You have what we call continuous glucose monitoring now. Continuous glucose monitoring, and your healthcare provider can access that data on the spot. The healthcare provider does not have to be sitting down waiting. If there's an abnormality, AI will tell you because the AI has already been programmed. And once you experience X reading at so time, alerts the healthcare provider. That's going to happen. So we're going to have more remote monitoring. We're going to have more telemedicine. We're going to have more AI decision making. We're going to have more AI in diagnostics and review of radiology reports, and many, many more things. Many more things. We're going to have more robotics, more machine learning out there. More of the research is also going to be done by AI. Off the top of my head, those are the few things that I think will happen over the next 2 to 4 years.
All right, sir. Thank you so much for this conversation. We'll be opening the floor to questions from the audience. So if you have anything, any areas you need clarification on, please drop a message in the chat box and then we can just tackle them one by one before rounding up. I was going to ask questions about cost of care and the role of governmental policy in integration, but I think you've touched on that a bit from the absence of regulation or regulatory bodies for
Yeah.
telemedicine in Nigeria and the role of a private sector in taking the big leaps ahead. But while we are waiting for the um questions in the chat box, I'm personally curious about financing and avoiding catastrophic care. You're a
Yeah.
primary care physician, sir,
Yeah.
and looking at the comparative cost of coming to the hospital, like you mentioned, the direct and indirect cost and utilization of platforms like yours, which would you say is much more cost effective, considering the value, considering the value afforded to the patient, and what steps do you think will still help drive down that cost further?
Okay, so technology integration and technological transformation has an upfront cost. So it's going to be expensive upfront. Putting tablets in 774 wards or primary care centers across the country is going to cost us a little. Then getting the AI algorithms and getting it installed, doing all the training, there will be front-loaded costs for that. Overall, the cost is going to come down and there will be more efficiency. Now, in terms of catastrophic healthcare expenditure, why is healthcare expensive? That's the first question. The cost of our training, it takes so long for us to train. There are few of us. You have a lot of diagnostics and you have a lot of investigations and then the drugs. So, what part of this can technology improve efficiency of? I remember when we started using cell phones, it was very, very expensive to even buy the SIM. Now it's free because many people. So if you can get scale, if you can get scale of anything, the prices typically come down. As of course, except for iPhones and S24 Ultra or something. Those things don't come down for some reason. Anyway, if you can get, like I said, if you can get more people to prepay for their healthcare, you can get more people to prepay for their healthcare. Overall, it becomes less expensive. And to do this, you need some form of ways of collecting that resources and allocating it efficiently. If I use telemedicine, I have less doctors. That example I gave was it's so live. 60 locations across Lagos, Ogun State, Ibadan, Port Harcourt, Benin, and Abuja. 60 locations, but I have only 8 doctors. But if I had to put up, even if it's a mushroom clinic, I have one doctor in all those. That's 60 doctors automatically. Or even if the doctors can rotate, you will still need a lot. So it will bring down my cost a little. That way, when I'm charging a patient, I charge less. If I charge you 500 naira consultation, but if I had a brick and mortar station, I cannot do that because I just can't because my operating expense is much higher. I'll stop there, but there are many ways of using technology to reduce costs. Blessing Joy, your hand is up. Please go ahead.
Hello, good evening.
Good evening.
Oh, are we allowed to like speak?
Sure. Please go ahead.
Right. Oh, okay. Once again, good evening.
Good evening.
My name is Blessing. Obviously, I am a biomedical engineering graduate student, based in Europe currently,
Okay.
and my field of research basically is human-computer interaction, interactive design, and the likes. But as a personal interest, I am interested in bioethics. And while I've heard you and a lot of other people speak about the potentials of of technology in healthcare delivery and accessibility in Africa and sub-Saharan Africa, something I can't help but notice every time people talk about this is the lack of or the non-inclusion of data privacy laws and cybersecurity, especially
Mm.
because we are talking about technological interventions in the global south, in sub-Saharan Africa, a highly poor um, location, and we know that the consequence of this sometimes can be that when data is being honest, when, for example, from electronic health records and all that, when they are being used, is there any protection being made for the patients? Because again, we know that these are areas with high incidence of illiteracy, and that is even completely different from inaccessibility and poverty. We know that illiteracy in of itself is a problem on its own, and because of that, consent given and all that jazz can be very, very difficult to get. And at what point, for example, your startup, what are the data privacy laws that, or what are the data privacy, or the ethical implications of that? How are you able to walk that line? Because as far as I know, or to the best of my knowledge, I don't think that we have sufficient data privacy laws, for example, in Nigeria, because I don't think we have a strong.
I think I understand where
Yeah,
you're driving
so
at.
my question basically is just really for all the potentials of what technology can do in Africa and all that, what is being done in terms of data privacy and protecting these people that we are using, because there is a power imbalance here for basically. Thank
Okay.
you.
Yeah. So thank you very much. That's a very brilliant question. Um, so first thing I would like to correct. First of all, we have the data privacy laws. We have very good laws. The implementation of those laws is the issue. That's one. So a lot of us, for instance, with the paper records that we have, somebody can just flip through it and look at patient records and all of that and start gossiping. And gossiping is even the least of the problems. Selling data is another issue. So we do have those laws. We ensure that we follow those laws at M Pharma. This is unfortunately self-regulation. This is us doing it because, first of all, we have investors from the US and UK and everywhere, and it was an issue in terms of how do you manage data. So we have our own electronic health record. It's called Bloom. It allows us to provide to store the records in one place. And during the registration process, patients give consent in quotes. And I put that in quotes because all of us, when we install your iOS software or your Android software, we just tick, I agree. So we try to tell patients one or two things verbally. Your records will only be used for your care. It will not be shared with any external party outside of the organization. And we tell them some basic things about the data privacy. Most people just say, I just want to see the doctor, I consent. So people don't really take time to understand it, unfortunately. And it's not just a Nigerian or African thing. Abroad too, people don't take people consent to all sorts, and they don't know the full details. So we need to have stronger regulation and monitoring of data privacy laws. In Nigeria, they told us we needed that. Nobody has come to check. We do have Amazon Web Services, Amazon Cloud Services. That's where we store all our data. It's cordoned for Africa. The server, unfortunately, is not in Nigeria. The server is in South Africa. But we do have that. In Ghana, the issue also came up. When we were trying to get a license in Rwanda, it was a big issue. They wanted us to actually set up the server in Rwanda. We're not able to get that process. So we were not able to get our license in Rwanda because of that. So I don't think we can say generally that we don't have data privacy laws. We have them. Monitoring and, of course, prosecuting people that breach these laws is a bit of a challenge. And note, even abroad, there's data breaches every now and then. There was ransomware a few years ago where people hack into the data and ask hospitals to pay money to release the data. So this is not just random data on Facebook, because Facebook also had data breach. Temu in China had data breach. Alibaba had data breach. So data breach can occur anywhere. But the difference is abroad, you are prosecuted heavily for it. And that's something that we need to bring to our own environment. Also, we need to enforce it such that people actually give informed consent before they collect people's data. So that's why I said that's a very brilliant question. It's something that needs to be worked on, and it's a challenge that needs to be overcome when we talk about AI, telemedicine, and all of that. I hope that answers your question. I can see another question on the chat box. Somebody talking about a physical examination. Again, physical examination is not very easy via telemedicine. But we do, like I said earlier, we have a device, it's a TitleCare Pro device. You can Google it, TytoCare, TitleCare. You Google it, it allows us to do remote examination. There's a lot of information on it. It's an FDA approved device. So I can listen to heart sounds, breath sounds. I can look into the ears, look into the throat, and do some form of examination. Again, you can do real time if you have minimum of 3G speed of data. We currently have 5G in many places, but 3G, if you have 3G, you can do real-time examination. If you don't have 3G, you can do a recorded version and send when you get to a place where there's data, and then the doctor listens to it and makes a diagnosis and sends a prescription and stuff like that. It's not everywhere, it's not widely available, and it's expensive. So most places that have telemedicine do not have the physical examination component. Even we that have it, it's costing us quite a bit to have that care. It's something that needs to be worked on. It's a challenge with telemedicine generally, where people want that touch, and it also helps complement our diagnosis. But in medicine, most diagnoses are made from history, then complemented with physical examination and then investigation, like I said earlier.
All right, sir. Due to our time constraints, I think the other questions, okay, Ms. Oladujoye's questions have been answered. So, Toluwani Oluwafemi is asking about opportunities for health tech and people not knowing where to start. They're interested in health tech, asking for suggestions on where to start when looking for job opportunities, courses to take, and things like that. Well, I think being a community like this has already given me one leg up. I don't know if my
No,
author
that's
has any other
it.
thing to add.
Networking with people will help. Will be a start. For instance, if I'm hiring doctors, I'll definitely need people that are willing to work with telemedicine. That's one way. But telemedicine is just a scratch in health technology space. People are doing all sorts. Doing online courses. If you go on Coursera, you'll find AI in healthcare courses available there. Go on, there are many. So get yourself certified. That way you are able to do things. There's actually an arm of Google called Google Health. There's YouTube Health. There's Amazon Health, all dedicated to health technology. So there's Apple Health now. So people work in there. They have clinical scientists, they have product designers, they have the people that do the coding and all of that. But they also have clinicians that help, because there's no point in bringing out a product that is useless to everybody. So you need clinicians. So you can get in there with only your clinical knowledge. You can get in there with coding skills. You can get in there with AI in healthcare certifications. So just do that. And of course, networking, getting to know people that are in the tech space. And those are basic advice that I can give. Farida.
Hello, good evening, sir. Thank you very much for your presentation. So here's my question. Um, I've noticed that, and you've also alluded to that this evening, that most health tech companies, or not health tech companies, you've mentioned how pharmacies, like local pharmacies, are fast becoming a point of innovation for people who want to access healthcare. Now, bringing this to individuals who are trying to innovate in just healthcare provision and not necessarily pharmaceuticals. So they're just providing access to consultations and just that. I've noticed that private startups that focus on that in this country, they tend to not break even, they fold up, except
Yeah.
when they are combining all like the full suite from diagnosis to prescriptions, because people will always still tend towards pharmaceuticals. Based on your own experience, do you see a future where people, because sorry to go back again, because even when startups that are focused on providing healthcare, like in terms of consultation only, even when they partner with pharmaceutical companies, they still people will still tend to move towards the pharmaceuticals, right? So do you see a future where innovation in just diagnostics will work in terms of AI? And yeah, do you just really see how that can work without the pharmaceuticals, just as a standalone?
Okay. Yeah, that's another interesting question. So the first thing is I don't know how much experience you have in healthcare space. If somebody called me and asked me, I have headache, I have this, I have that, and I talk to the person and I tell the person, oh, yeah, pay me money. They don't want to pay because they don't think it's value. That's why the patients do not consider it value. Meanwhile, abroad, just for consulting, you pay. If the nurse practitioner speaks to you, you pay. If doctor speaks to you, you pay. If you do a lab test and somebody interprets it, you pay for it, and you've not even gotten drugs at all. So our patients currently do not see value in the consultation, in counseling. People pay for counseling abroad. In Nigeria too, in some hospitals you charge for counseling, but generally just for counseling people don't want to pay for it because they know the information is useful, but they don't value it. So it's until they get drugs, and that's why the drugs they sell in hospitals are 2-3x more than what they sell in community pharmacy, because that's the place where the doctors and healthcare providers can get money from, because people value the drugs more. I've had somebody ask someone to do a CT scan before, had a funny complication and did a CT scan, and the CT scan came out normal. And the patient said, so I spent 35,000 for nothing. I said, knowing that you don't have this complaint is nothing, how can you consider that nothing? Or would you prefer I saw cancer there? Of course, the person said, God forbid. But the truth is, people don't value anything that is not tangible. One main reason is because we are paying out of pocket. That's one main reason. We pay out of pocket. So when you pay out of pocket, you want to see something to hold on to. And that's why drugs come in. You see people spending thousands on GNLD products, on some herbal this, on herbal that, on all of that. So that's why all these agbo will sell, all these herbal things, all these supplements will sell more than your consultation, because people want to hold on to something. And that's why we also have a challenge with preventive care, because people pay out of pocket. If somebody was funding it, or if it was health insurance, they won't mind the consultation, and they won't mind. And of course, the health insurance will pay the person doing the consultation. But that you pay, and then all they say is X, Y, and Z, and nothing else. Patients don't value that. So that's the main reason in our environment. So do I see a future? If we get our health financing right, then yes, eventually it will come up. And even within M-Pharma, we are working within the retail space because we own those pharmacies, we have partnership with those pharmacies, and we get a lot of our money from the drugs we sell at the end of the day, even though the consultation is what pulls the patient, and then we sell, and then we get. So either way, we have to tie it one way or another, because of the population we are dealing with. The population do not value just counseling or just consultation. And that's why you go to the hospital and you tell somebody consultation fee is 20,000. Say, how can you pay 20,000 for consultation? They shout. So doctors would rather mark up the drugs or mark up the lab tests than to mark up consultations in the first place, because patients don't value it.
All right. For
Thank
the
you,
sake
sir.
of our time, we'll just be taking the questions in the chat box one by one.
Okay. Can you read them for me, please?
Okay, sir. So we've taken the first question from Toluwani Oluwafemi and Oladunjoye's questions. Deborah Abueji is also asking about the challenge of lack of physical examination, but I think that has been answered.
Yeah.
But if it has not been clarified to your satisfaction, Deborah, you can just drop another comment. Oluwapelumi Ajiboye is asking about the role, breakthroughs, and opportunities of design in health tech and telemedicine. So I don't know if you have anything to
What kind of
mention.
design? When you say design, I'm assuming user interface and user experience designs. If that's what it is, then yes, there's a big role for it. Um, I imagine or I envisage a time. So I have friends that are partners in consulting firms they work with major oil companies and things like that, or tech companies, and they really don't have time to go to the hospital. If there's an awesome user interface where they can um, just click on this, click on that, either speak directly to a healthcare professional or have an AI give them relevant, useful information. There's always a role for that. But it's a small niche. It's a small proportion of the market that are bothered about those types of designs. But then those people exist really. They don't have the time. I don't know if you ever followed the Obamacare issue. The people in Silicon Valley were saying they do not typically go to hospitals. And that's the truth. So why should they pay? But if they had access to some form of experience website app that can help them access the care and it's still good quality, they will use it. But it's a small proportion of the population. Yeah. Next question, please.
Okay. Just following up to that, someone, Deborah Ojo, asked about service design in healthcare,
Service
in health
design.
tech. Yes. So I don't know
Uh,
if you have anything to add about that.
if I understand the question, in fact I don't understand the question. What kind of services are we talking about? I wish I
Okay. Deborah, you can maybe add more context in the chat box while we go to the next question. Courses in technology, that question has been answered. The challenge, the host account asking about challenge in financially sustaining primary healthcare tech solutions. I think the question I asked you, sir, tackled this about the reducing the cost per facility and integrating it into smaller booths.
yeah.
Then, okay, someone is asking for Miss Halimat Shaibu is asking for the device, the name of the device for physical examination.
Title
Maybe,
care. Title care. TYTOCARE. Title care.
thank you
It was
so much
designed
for
by an
that.
Israeli company. It was designed by an Israeli company and approved by the FDA. So we have a partnership with them. So title care, there's a lot of YouTube videos on it. There's a lot of they're on LinkedIn. They're everywhere. A lot of insurance companies in the US use title care for home care. So people buy the device and have it at home, and they can connect to their doctor. Okay, please go ahead.
Okay, the next question from David Adeleye is asking, and I'm reading out now. In a world where AI and ML are evolving light years every day, with diagnosis hitting 90 plus accuracy, as health professionals, how do you build long-term stay with potential of patients being their healthcare providers in the coming future? I'm guessing that means potential of patients being their own healthcare
Yeah,
providers.
yeah,
Um, so maybe before your answer, I think he mentioned a bit of that, which you can probably give further context, sir, about some specialties probably being more affected. You mentioned radiology in particular.
yeah.
So,
No,
sir,
so
just
the
for
truth
a
is,
few minutes.
as healthcare professionals, we cannot afford not to be involved in AI in healthcare and machine learning and all of that. It's not kicking off yet, but like you said, very soon patients will start taking care of themselves because they will ask AI, and AI will give them solutions that are almost as good as human beings. In fact, sometimes better. So what you need to do is to get educated, get informed about it. Uh, it's it's people, like I said, it's people who do not get informed or educated that will get thrown out of the business. But healthcare will evolve. The training of healthcare providers will also evolve with AI and machine learning eventually. Um, it's going to take a bit more time in Africa, but abroad, it's definitely going to it's going to evolve much faster. primary care providers will have AI help them be more efficient with their work. So all the time used in documentation, all the time used in scheduling appointment, all of that is going to be taken over by AI. So you just tell the thing to schedule the appointment, give her a 3-week appointment, and an AI will recognize it and give it. The notes will be text to speech. Speech to text will continue as you're asking the question. The AI is taking your notes, so your notes is going to go. You won't have to type anything anymore. Then making the diagnosis, what your job will be is reviewing the differential that AI is providing. But if you don't know how to review it, then you are going to be left behind. So you review the diagnosis that AI is providing and then rule the required ones out and order the prescriptions. And then when the results come out, AI will help you interpret some of them. You will also make some sense out of some of the others. But generally, if you think it will not affect you and you don't want to learn about it, you'll be sorely mistaken. So just you need to learn about it and evolve with the trend.
Okay, thank you very much, sir. I think this is a personal opinion. The evolution of practice of clinical medicine today is moving more towards oversight function from doctors rather than hands-on. And you can
Yeah.
see that in the US and the UK, where you're having physician associates, nursing care practitioners doing more of the daily hands-on with more oversight by the doctors. So it's up to you. If you then decide to still stick to clinical medicine, this is
Then you choose
again
a subspecialty that
pragmatically speaking, yes,
you have to choose a
it's
subspecialty that will not be easily disrupted. For instance,
yes.
I'm not sure if an AI can do an endoscope. An AI can interpret the endoscope probably in the near future, but the actual process of doing a gastroenterologist will probably still remain relevant. Doing your percutaneous something cholangiography, transpancreatic cholangiography,
Pancreatography.
for instance. Yeah, the AI will not be able to do it, but it might be able to interpret the images. So it will help you if you know how to put the right prompts and command to the AI. I hope you know there's something called prompt engineering now, where you
Yes.
knowing what to type. Knowing what to type is a specialty now, and not just for healthcare in many things. So just knowing what to type and ask the AI is becoming a specialty. So understanding the prompts to put in, and it will help you do your job better and be more efficient in whatever it is you are doing. So AI is going to complement what we are doing and going to make us more efficient and more effective eventually. And as I speak now, even me, I need to go and start doing more courses and training. Telemedicine is just a scratch, like I said.
Okay, thank you so much, sir. So, because of time, we would like to round up before 9:30, 9:35. Moving to the next question. Is there a role of blockchain technology in healthcare? Is there anything you'd like to add to this, sir, from your knowledge?
Unfortunately, the blockchain technology, I do not understand it properly, but I do believe there's definitely going to be a role for it in healthcare. I've heard it being motored in different spaces. I do understand the technology itself. And most healthcare professionals probably do not need to know the details of the blockchain technology. They just need to know how to use it whenever it's out there. So that's what it is. I believe that there will be a role. I can't give you specific examples because I don't understand the technology yet, but there will definitely be a role because it's being used in the finance space. It's being used in many other spaces. So there's nothing that says healthcare will be. It's already being used in research actually. So there's nothing that says healthcare will not be next in it.
Okay. So, to the next question from Kafaya Saka, and I read, in your experience in the health tech space and your organization, you deal with a lot of data. What role will you say you hire for? Okay, let me take that again and use better English. What role will you say you hire for more or is of more importance to the health tech space? That's between a data scientist, a data engineer, or a data analyst. Or does one person handle all? So I'm guessing she's coming from a place of migration to a total non-clinical role.
Okay. So you need to know the difference. A data analyst could analyze the data, and a data scientist will make sense of the data. Two different things entirely. So for me, a data scientist is more important. But typically, data scientists know how to do data analysis. So data analyst will help me group my data together, but a data scientist is the one that's going to tell me that, look, based on this data, you need to start a program on diabetes training, because your data shows that you have 25% of the population having pre-diabetes, and based on X, Y, and Z, these people are going to likely transform to full-blown diabetes. So a data scientist will probably be more effective than a data analyst in the healthcare space. But then
Okay, thank you.
data analysis will not go anywhere. And we need more of it now because there's so much data out there, nobody's doing anything with it.
Okay, maybe I would shoot my shot after this with your company staff. Okay, to the next question. Okay, this is context to the question I was asked earlier about service design.
Yeah.
So she mentions that service design is an aspect of product design, which is a collaborative and holistic approach to creating and improving services. It involves understanding user experience, mapping out the service process, and designing solutions to enhance the overall quality of the service. The goal is to provide a seamless and satisfying experience for both customers and service providers. So that is the meaning of service design. So her question then is, if I get trained as a service designer in healthcare, what does my future look like in the African healthcare market?
Okay, so I imagine that such a person will be um, an operations manager, healthcare operations person. So, for instance, I remember when I went to Lasut, I went to see an ophthalmologist. So the first thing I did after the registration process was to go to one room where they did my visual acuity. Okay. After doing the visual acuity, they told me to go and, oh no, they told me to go to one room where they would do my visual acuity, but I should go and pay first. But something told me that they're not only going to do visual acuity, they're still going to do tonometry. That's to check the pressure in my eye and all of that. And I probably will have to pay for it. So I asked, so am I going to pay for it? They said yes. So I said, where would that be? He says in the next room. That's such an inefficient system. So what I will have done is I will go there, go and pay for the visual acuity. Then I'll go back. After doing visual acuity, they'll say I should go to the room that they're going to do the pressure of my eyes, the tonometry. Then I'll go and pay first and then come back. Such an inefficient system. So I imagine that somebody that is an operations manager, healthcare operations manager, will be the one that will redesign the entire system so that it's patient friendly, it flows accordingly, reduces time wasting, and improves the overall patient experience. That's what I imagine that person will do. However, having said all of this, I don't think we're there yet. So if you did it now, today, people will not even know your function. The only reason why I can speak about this is because I did some things on project management and operations and all of that and all of that. So I understand what you're saying with regards to healthcare, how it can be applied. But a lot of people that are in the helm of affairs do not even know what you're talking about. If you go to Lutz, for instance, you almost run mad with the processes for healthcare. You almost run mad because it's so inefficient, it's so disorganized. However, with that service delivery process and process management to make it more efficient and more streamlined, and I think there's a role for it, but probably not just yet.
I th- I think the conversation has a bit more context because the individual asking is even in Luth. So, so
That's
to the next question, because we have to wrap up very soon. How can AI developers get quality data access from various hospitals? Well, of course, our guy is going to answer, but I can, even as an entry level doctor, I can tell you that that is almost impossible. I'm
you
currently
don't
doing a
there's
study on micro MCS results, microscopic culture and sensitivity. And you literally have to pull it out from one hardcover book
yep.
as gathered dust somewhere. And aside
Yep.
that, there's a lot of data siloing in Nigeria. Well,
Mhm.
leave open the floor to for your response, sir.
No. I completely understand what you're talking about. And so there's data, but it's not usable data. It's useless data. Any data that's not usable is useless. Oh well, that's almost intuitive. Is intuitive on its own. So the idea is the data is there, but it's raw. And once data is raw, it's difficult to analyze. And now you are doing it raw you're going to the hardcover book and you're copying it. Unfortunately, somebody is supposed to be paid to put all this data on a system such that you use Power BI, for instance, to analyze that data and you get everything you need, or use Excel or whatever. But that data is currently on the floor and not on the system. And even when it gets on the system, it still needs to be cleaned for it to be usable. Because some people write MCS, another person will write microscopic culture and sensitivity, another person will write microscopy, another person will write culture and sensitivity only. You need to clean this data for it to be usable. It has to first of all be entered into a data storage system, and that's why we talked about either electronic health record or health information management system. There are rooms as big as 2-story buildings with files upon files gathering dust in 1960 something that LUT was established. All that data is not useful. It's there, but it's not useful because you cannot use it to plan anything because that data is not in a usable format. So if anybody, I remember when I wanted to do my part 2 project for my family medicine residency, I wanted to collect birth outcomes of pregnant women. Birth outcomes. What does the birth outcome mean? What was the 5 minutes APGAR score? What was the birth weight of the baby? And what else? I think there was one more thing I wanted to check. But the issue is I had to go to files to be checking one by one. So some people that I collected their data while they were pregnant, I have to go and wait for them to deliver and go and look for their file again. And sometimes because they deliver via CS, the file is somewhere else, or because they are owing something, their file is somewhere else. But if as they gave birth, the data is imputed on the system, I can just go and check patient number XYZ because you anonymize the data. Patient number XYZ, when was the date of delivery? What was the birth weight of the baby? What was the birth outcome, 5 minutes out gap score? And I can get it online. But I had to check files upon files. And imagine how tedious that was. And I had to do it. I had to do it for me to even make sense of anything that I was trying to do. But it was horrific. I was sleeping under the step. So the files were stored under one step. You go there. In fact, to tell you how bad it was, there was a chair there and there was a bed there. So that's to tell you that some people sleep there because they have to go and look for files for the next clinic day. So it's such an inefficient system, and unfortunately, there's nothing we can do about it yet until we take it seriously.
Yes. So, the next question is.
I think we should make this our last question. It's already
Okay.
7.
Okay, sir. Okay. So, people are asking. I'm also curious, sir, about entry-level roles in M-Pharma and if you have internship opportunities available. I'm also asking, this is before my last question for you for tonight.
Okay. In my unit, I can create internship roles, but I don't like unpaid internship. I don't like it. I think it's unfair. So we need to have a structured way of doing it within the organization where you have internship and people can then graduate into a permanent role or they carry their experience elsewhere. So for data, for instance, I have a lot of data that I'm mining. I have people in-house who actually do clinical work, but also trying to do data and all of this analytics. So within M-Pharma, we have entry-level marketing roles, we have entry-level sales roles, we have internship in all those places. But in the healthcare clinical services, we'll have to create the internship role, but that will take some time because, like I said, I don't want you to be unpaid. Unless you absolutely beg me to be unpaid and you say, it's me that said I want to be unpaid. Now, I'll have to create the role and then find a way of funding it. You know the way it is in private organization, you have to justify the ROI and then somebody has to fund it. So that's
Yes,
it.
sir. Okay. I think my last question will be from the place of people that are. I know a lot of people in this conversation are still students, and
Yeah.
probably have assumed that as they are leaving school, they most likely will leave clinical medicine totally. I myself
That's a
was one
shame
of
though.
those. I was one of those people before until I started my housemanship, which I'm almost done with, and now I'm seeing the advantages of a clinical perspective to things. And you've been able to span two worlds, or will I even say three? The MPH, that's the clinical, or let me say health non-clinical roles, then
Yeah.
health clinical roles, and business, that's the MBA.
Yeah. Yeah.
What advantages and disadvantages would you say that your unique perspective has given you for your journey so far?
Okay. So the advantage is I can easily become a health administrator. So for instance, I don't do clinical medicine in M Pharma. I oversee the healthcare that is being delivered, the quality of care, of course, but because it's a business, I also have to oversee returns on investments and things like that. So my clinical orientation helps me to be able to direct the organization and tell them, look, it doesn't make sense for us to do this for either for cost reasons or for safety reasons. My boss is not a clinician. He can tell me he wants me to start offering X number of services, and I'm like, no way, I cannot do that because we cannot safely deliver this service within this space that we are acting. So as a clinician, I'm able to do that. But I can also be an administrator, which is what I'm currently doing, managing people, building teams, hiring, and all those kinds of things. I can also be an administrator. But I've also worked in the pharmaceutical space. So when we have partnership with pharma companies like the Pfizer's, the Novartis, the Boehringer Ingelheim, and Sanofi's and co, I'm able to speak their language because I understand what they call pharmaceutical medical affairs because I did it. Those are advantages. It gives me a broad general knowledge of many things. Unfortunately, my broad knowledge makes people confused about what to do with me. If you want to hire me, for instance, they think I'm spread out too thin. Some people think I'm spread out too thin because they think you are not focused only on pharmaceutical care, so you're not involved in clinical development. That's the process of new drugs development
Drug
and all of that.
development.
Yeah, new drug development. And you're not a health economist, so you're not focused on health economics and outcomes research, and you're not. So I can only work in spaces where there's requirements for administrative and pure clinical role. So I have an advantage that I have a broad knowledge, but there can be a disadvantage. If I had to do it over again, I'll probably ditch the residency part and rather do health economics and a PhD or something in health economics. That's what I'll probably do. Yeah.
So
Of
I
course.
literally just changed my mind 6 months ago to do a residency program, and now you are.
No. So residency. So I did family medicine. It's one of the most fulfilling residency training as far as I am concerned, because from my experience, you can see that I keep jumping from here and there almost because I can get bored. So I can't stand the fact that I'll be seeing only women from morning till night as a gynecologist, or seeing only children, or looking through only the eyes and doing ophthalmology or something. I'm able to see a 6-month-old baby and intubate that baby if the baby has a crisis, and the next thing I'm doing a cesarean section and delivering another person, or doing a heniography, or then I'm seeing an old man that has a prostate cancer. So I like the broad perspective. I enjoy it. I think it's more fulfilling for me. And everybody starts calling you doctor, and they start asking you random questions, and they expect you to know. Meanwhile, you're an ophthalmologist. Or you're a cardiologist, you only know the heart, and they're asking you about the prostate, and you're wondering, what are you talking about? So family medicine gives me that broad perspective, and I feel more fulfilled about it. It's unfortunate that I dropped out of clinical medicine in the sense that I don't actually see patients one-on-one, but my clinical skills are still very useful. And I think in future, I probably will come back. And maybe if I become the CMD of LUT, nobody can tell me in the radiology department that this is what I need, and I will understand what they're saying because of my broad perspective. So that's me selling family medicine for those of you that might be interested. And of course, you can easily
Thank you
emigrate to
so
Canada.
much, sir.
Canada is looking for family physicians.
Thank you so much, sir. I really enjoyed this conversation with you, and I'm pretty sure people in listening also did, going by the number of questions that came up. If you do not mind, sir, because of individuals asking about the rules and whatnot, maybe someone wants to beg for the unpaid internship. Do
I'll
you
send
mind
you my
dropping your
official email address. I'm putting it in the
yes?
chat box.
Okay. I will be
Just
sending a very
introduce yourself, and remind me that you are in this webinar. And
I will also be sending my own very long, detailed email to you.
no problem. That's my email address there. I'll try and respond as much as possible. The person that organized this, Ekundai or something, Isaac, is not here.
No, I am here, sir.
Oh, okay. I can see you now. Okay. I wasn't seeing you. All right. Thank you very much. I actually thought I'll be out of here in 1 hour. I've ended up being 1 hour 43 minutes. So
Thank you so very much for joining us, sir.
no, you're welcome. You're welcome. It's my pleasure.
I really
Thank
learned
you.
a lot.
Yeah, I'm glad you did. I am also learning. So, and if you have any additional things to teach me, I'm open, because I like I said earlier, in terms of technology, younger people are more advanced than those of us. I graduated 2005, so almost 20 years now. So it's a long time. I need to learn more. Thank you, everyone. My email is there. You can always reach out to me, and I'm glad I was able to do this. Do enjoy the rest of your day. Bye.
Thank you
Okay,
so much,
thank you
sir.
so much, sir. All right, thank you so much for attending today's webinar. I hope you learned something. I'm Olorunfemi again, and if you want to do any work on health policy, finance, health operations, please feel free to reach out via LinkedIn or email. Do have a lovely day.